Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of Variegate Porphyria, designed for general pediatricians in active clinical practice. Variegate Porphyria is an acute hepatic porphyria with a distinctive mixed phenotype, combining acute neurovisceral attacks with cutaneous photosensitivity. Across this lecture, we will work through 13 carefully constructed clinical cases. We will cover clinical presentation, pediatric onset, recognition of an acute attack, skin and neurological findings, the underlying enzyme defect and pathophysiology, diagnostic and confirmatory testing, classification, differential diagnosis, acute attack management, and long-term prevention. Let us get into it. Question 1. A 16-year-old female presents with a 3-day history of severe colicky abdominal pain, along with vomiting and constipation. She is agitated with a heart rate of 118 beats per minute and a blood pressure of 148/92 millimeters of mercury. Her urine is dark reddish-brown. Importantly, she recently started both a weight loss diet and oral contraceptives. Which is the most likely diagnosis? Option A, acute appendicitis. Option B, acute intermittent porphyria. Option C, variegate porphyria. Option D, porphyria cutanea tarda. Consider the combination of an acute neurovisceral attack with classic triggers and think about which porphyria fits best. The correct answer is option C, variegate porphyria. This patient is having an acute neurovisceral attack, shown by the severe abdominal pain and the dark urine. The recent triggers are classic. Dieting and starting hormonal contraceptives both precipitate attacks. What points specifically to variegate porphyria is that it is a mixed porphyria, capable of producing both acute attacks and cutaneous photosensitivity. This separates it from acute intermittent porphyria, which causes acute attacks but no skin signs, and from porphyria cutanea tarda, which causes skin disease but no acute attacks. In a teenager with an acute attack plus a tendency to photosensitive skin lesions, variegate porphyria should be high on the list. Question 2. A 9-year-old boy is brought to clinic with recurrent blistering lesions on his hands and face after sun exposure, along with skin fragility and small milia. He had one episode of severe abdominal pain with vomiting last year that resolved on its own. Which feature is most characteristic of his likely condition? Option A, autosomal dominant inheritance. Option B, X-linked recessive inheritance. Option C, onset always before the age of 5 years. Option D, complete penetrance in gene carriers. Think about how variegate porphyria is inherited and how reliably carriers actually develop symptoms. The correct answer is option A, autosomal dominant inheritance. Variegate porphyria is inherited in an autosomal dominant pattern, but with low penetrance. Only around 10 to 15% of carriers actually develop symptoms. This means option D is incorrect because penetrance is far from complete. Pediatric onset is rare but well documented, and when it does occur in children, it tends to show cutaneous manifestations, as in this boy. The combination here is very telling. Photosensitive blistering skin lesions, together with a past episode of an acute abdominal attack, strongly suggests variegate porphyria, because that mixed picture is its hallmark. Question 3. A 14-year-old girl presents with severe abdominal pain, persistent vomiting, constipation, confusion, and agitation. She is afebrile. Her key findings are a heart rate of 128 beats per minute, a blood pressure of 156/98 millimeters of mercury, a sodium of 122 milliequivalents per liter, which is low, a potassium of 3.2 milliequivalents per liter, which is also low, and dark red urine. Which additional finding would most strongly support a diagnosis of acute porphyria? Option A, elevated serum amylase. Option B, elevated urine porphobilinogen. Option C, elevated blood glucose. Option D, leukocytosis with a left shift. Think about the single biochemical marker that defines an acute porphyric attack. The correct answer is option B, elevated urine porphobilinogen. During an acute attack, urine porphobilinogen is markedly elevated, typically above 10 milligrams per gram of creatinine, and often 5 to 50 times the normal level. This finding is essentially diagnostic for the acute hepatic porphyrias, which include acute intermittent porphyria, variegate porphyria, and hereditary coproporphyria. It also explains the rest of this girl's picture: hyponatremia, often from the syndrome of inappropriate antidiuretic hormone secretion, autonomic instability with tachycardia and hypertension, and neuropsychiatric symptoms such as confusion and agitation. So in a suspected acute attack, measuring urine porphobilinogen is the key step. Question 4. A 17-year-old female with known Variegate Porphyria presents with several tense bulli on the back of both hands, along with erosions, crusting, and atrophic scars. She also has increased facial hair on her temples and cheeks. Which additional finding is most commonly associated with the skin manifestations of Variegate Porphyria? Option A, joint swelling and arthritis. Option B, skin fragility on sun-exposed areas. Option C, palmar erythema. Option D, digital clubbing. Picture the typical sun-exposed skin in this disease as you weigh the options. The correct answer is option B, skin fragility on sun-exposed areas. The cutaneous manifestations of Variegate Porphyria cluster on light-exposed skin, especially the backs of the hands and the face. The key findings are tense bullae, erosions, melia, scarring, hyperpigmentation, and increased hair growth, known as hypertrichosis, along with marked skin fragility. The underlying mechanism is a phototoxic reaction. Accumulated porphyrins, such as coproporphyrin 3 and protoporphyrin 9, absorb light and generate tissue damage. These skin changes are clinically very similar to those of Porphyria cutanea tarda, which is why the acute attack history is what tips the diagnosis toward Variegate Porphyria. Question 5. A 19-year-old male is in an acute attack with progressive weakness developing over 5 days. Examination shows a flaccid quadriparesis that is more proximal than distal, universally diminished deep tendon reflexes, and flexor plantar responses. He requires mechanical ventilation. Which condition does this presentation most closely mimic? Option A, Guillain-Barré syndrome. Option B, myasthenia gravis. Option C, botulism. Option D, transverse myelitis. Think about which neuromuscular emergency produces this exact pattern of ascending flaccid weakness with areflexia. The correct answer is option A, Guillain-Barré syndrome. The porphyric neuropathy of an acute attack presents as a rapidly progressive, predominantly motor axonal polyradiculopathy, and this closely mimics Guillain-Barré syndrome. Several features point back toward porphyria rather than Guillain-Barré syndrome. A preceding episode of abdominal pain, autonomic dysfunction such as tachycardia and hypertension, hyponatremia, and dark urine. There is also a useful laboratory distinction. In Guillain-Barré syndrome, the cerebrospinal fluid classically shows albuminocytologic dissociation, meaning a high protein with a normal cell count. In porphyric neuropathy, the cerebrospinal fluid protein is usually normal or only mildly raised, so that dissociation is typically absent. Question 6. A deficiency of protoporphyrinogen oxidase, the penultimate enzyme in heme biosynthesis, leads to variegate porphyria. Which metabolite primarily causes the neurovisceral symptoms? Option A, protoporphyrin 9. Option B, coproporphyrinogen 3. Option C,